Okay. And as per usual, if you guys have any questions, you can chat me or just ask. So we're gonna do repro pathophysiology. And I really wanted to emphasize the physiology aspect of the pathophys because again, first year is really about the phys. And what's interesting about repro is like if you understand the physiology, you will understand the path, especially when it comes to like the non-cancer repro path. Okay. Um, okay, so here's everything that I'm basically covering today. I wanted to go into polycystic ovarian syndrome. This came up like a ridiculous, like an absurd amount on my Comlex for some reason. So I wanted to go into that like right out the bat. Mullerian duct abnormalities, androgen insensitivity syndrome, sex chromosome disorders. I do a very brief, like boards relevant review of mitosis and meiosis, and then Klinefelters and Turners, and then a little bit on STIs and torch infections. I'm going to end with a bunch of questions. This is just, again, all the path I think is relevant for first year. Again, this is just what I think is important to kind of cover. Cancers and stuff is more so second year, not saying you can't have it, but it's just this is what I would focus on for first year is like the pathophys when phys goes bad. Okay, so starting with PCOS or polycystic ovarian syndrome. So, how you can kind of think about this as a potential differential is when the patient comes in and she either has primary amenorrhea or secondary amenorrhea. And remember, primary amenorrhea is where this however maybe she's like 15 or 16, she's like older and she's never gotten a period. So I would be like, maybe she has PCOS. Secondary amenorrhea is when you get your period, you have it, but then all of a sudden it stops. And then you can also have infertility with this. There's other symptoms of it. So insulin resistance, and there's other obviously things that cause insulin resistance diabetes, type 2 diabetes, also has similar presentation, but you can also see it with PCOS. And then some other things are hirsutism, which is basically when like women have male pattern hair growth, meaning like, they have like a mustache and like a beard, they have like back hair, like chest hair, things like that. Acanthosis nigricans, this is associated with insulin resistance, and I'll show you some pictures of that, and then acne. So this is kind of your picture of PCOS. If you're doing a vignette and all of this is in there, it's likely PCOS. So this is hirsutism over here on the left. This is like a female. This is an adult female, but notice how she has a ton of like male pattern hair growth. So she's got the beard, the mustache, yeah. This is acanthosis nigricans. So again, you're going to see this anywhere there's insulin resistance. So you're going to be learning about some other pathology states like moving through the blocks. And you can see acanthosis nigricans. It just means that the body is not responding to insulin. There's tons of insulin being produced and it's not responding to it. That happens in PCOS. It happens in type 2 diabetes. It happens in some cancers. So just keep that in mind. This is not at all specific to PCOS. But it is a really good way to kind of like figure like, oh, I think they're talking about PCOS because insulin resistance is associated with it. And usually where you can see acanthosis nigricans, it's basically this hyperpigmentation of the skin. So this is an armpit. So someone has their arm lifted up. See this hyperpigmentation here? That's acanthosis nigricans. This is like the back of the neck. You can see this hyperpigmentation here, same thing. But something interesting, and usually they'll talk about an armpit. I'm sure that's probably where they'll say it for you guys in vignettes and stuff. But anywhere that there's a fold of the skin, you can potentially see this. So I have seen questions before where there was like someone that was obese, and obesity is a symptom that can be a symptom of PCOS. In obese patients, they have like the belly rolls. You can actually get this hyperpigmentation within the belly rolls because that's folding where the skin is folding. Okay, so it's just anywhere skin folds, you can see this. That's usually where this kind of pops up, and it's a sign of insulin resistance. Okay, so I wanted to do a physio review because I don't know exactly where everyone is, especially for everyone that's going to be watching it this weekend, this video. I don't know where everyone is in their repro phys review, so I at least wanted to do a little bit of a physio review and then jump into like, hey, this is where it all goes wrong in PCOS. So we're going to talk about FSH and LH. So remember, we're in this hypothalamic pituitary axis. So the hypothalamus releases gonadotropin-releasing hormone, GnRH. This stimulates the anterior pituitary to release FSH and LH. FSH is going to stimulate the growing follicle. Remember, it's follicle stimulating hormone. So it stimulates the growing follicle by acting on granulosa cells. And this is just important, like just to have these, like what cells? Remember we talked about in the anatomy video, what FSH and LH act on in the testes. This is kind of the similar thing, but now we're in the ovaries in a female. So FSH is going to stimulate granulosa cells to secrete estrogen. LH is going to basically be what sparks ovulation. And we'll talk about this a little bit after the positive feedback. I think pregnancy is a really good way to ask Repro Phys. So you'll get a lot, I think, you'll get a lot of questions on pregnancy. I had a ton of questions on pregnancy my first year because I just think it's a really good way to test Repro Physiology. So if you've done pregnancy, if you remember your pregnancy physio studying, remember it switches from negative feedback to positive feedback. And that's when LH kind of does your LH surge, and that's when you get your big jump in estrogen, and that's kind of your ovulation. Not pregnancy, I'm sorry, the menstrual cycle. Sorry, not pregnancy. The menstrual cycle, it goes from negative feedback to positive feedback, and then it kind of goes back. But anyway, so LH then is going to act on the theca cells, and then the theca cells are going to produce androstenedione. Okay, following along. So this is normally what happens. So this is what I want to talk about, the menstrual cycle, the ovarian cycle, whatever you want to call it. So there's two phases. So the follicular phase, so this is going to be where the follicle is growing. This is going to be days 1 through 14. So a normal menstrual cycle is 28 days. The first 14 days is your follicular phase. And you can think of this as day 1 of menses to the day right before the LH surge. Okay? And I always remembered this because once you have the LH surge, that's the luteal phase, and I always lined up the L's, so the luteal to LH, so that's how I remembered like what the exactly 14 days is. So first day of menses to the day before the LH surge. This is where if someone has like a variable, like if you've ever heard someone say like, oh, their menstrual cycle varies in time, it's like, oh yeah, like it's kind of like all over the place how long it is. Where the variability is going to occur is during the follicular phase. So like if you've heard someone say like, oh, I have a 35-day cycle, the most of the variability in how long the follicular phase is, that's going to be what's variable. And I say this because the luteal phase is always 14 days. Does not matter. It's always going to be those last 14 days. Always. Okay, so if you have a longer menstrual cycle, the variability is happening from the follicular phase. You might have more days in the follicular phase. Okay, so that's what that means. The whole point of the follicular phase is to grow the follicle, right? So follicle stimulating hormone, we're trying to grow the follicle. And you can see this down here, like during the follicular phase, the follicle's growing, then it gets released, and then you're in the luteal phase. The follicle gets released when the LH surge happens. That's like the definition of ovulation, is when the follicle gets released. So that happens by the LH surge. We will talk about that. And then that's going to last exactly 14 days, no variability whatsoever. I actually think that might have been a question on my exam. And it seemed so like such like an innocent question, but then you're thinking about it and you're like, oh, I don't know which one is like. So the luteal phase is always 14 days. And then that's going to be until basically the start of the next menses is the luteal phase. And I have some more charts later to kind of show you like how it all goes about. But tying in FSH and LH, so FSH, like we talked about, stimulates development of several follicles in the ovaries. Then the granulosa cells are going to produce estrogen. We talked about that. Estrogen is going to suppress the release of FSH, right? So if you think about this, and I have a picture later where it's like FSH stimulates the granulosa cells to produce estrogen, and then you can see that feedback loop go back. So then it's like estrogen feeds back onto the anterior pituitary to basically stop the release of FSH. That's your negative feedback. Eventually, you're going to get the selection of a dominant follicle. This is called the Graafian follicle. That's just like a term to know that the dominant follicle is the Graafian follicle, because right now all the follicles are getting stimulated, but one is going to get selected. That's the Graafian follicle. At this point, you're going to get that switch from negative feedback to positive feedback. So when estrogen levels reach a certain like amount, when they get high enough, it's going to actually trigger even more FSH to get released, which is going to cause your LH surge, and that's going to spark ovulation. So you see this switch from negative to positive feedback. And I have a graph to kind of show you this, but that's like the big thing with the menstrual, like where it's like, oh, negative feedback. Oh, here's one example of positive feedback in the entire world of endocrinology, right? Okay, so this LH surge is critical to have ovulation, which is the release of that follicle. Okay. So then when we have the LH surge, we have ovulation. That's when the follicle ruptures, and then it's going to release the egg. And then following ovulation, the granulosa cell helps the ruptured Graafian follicle turn into the corpus luteum. It's another term. So the corpus luteum is basically just the ruptured Graafian follicle. And if we go back 2 slides, you can kind of see here, the egg gets released, and then now we have just the ruptured follicle. This is now the corpus luteum. It just changes its name. The corpus luteum is going to produce progesterone. Progesterone is going to feed back and stop the release of LH and FSH, and it's going to maintain the endometrium. Okay, so it's like the number one job of progesterone is to maintain the endometrium. If pregnancy does not occur, so this is now during the menses, so if there's no pregnancy there, or right before the menses, sorry, if no pregnancy is there, then the corpus luteum is going to regress. Here's another name, and then it eventually is called the corpus albicans. Okay, so it goes from Graafian follicle to ruptured Graafian follicle to corpus luteum to corpus albicans, and the corpus albicans is just when it like atrophies. It's not needed, so it goes away, kind of. All right, lots of words. Okay, so here is this chart. So here's the follicular phase, the luteal phase. They did it exactly 14 and 14. That's usually how it is. It's 14 days each. But you can see we have, so estrogen's in this purplish color. You can see it's low, low, low. Then all of a sudden it spikes up, and that's going to trigger the LH surge. So as soon as you see estrogen spike, that's going to trigger the LH surge. And this is really important. I keep emphasizing this over and over again, because if, let's say, estrogen levels are really high, like they just stay high the whole time, you're not going to get an LH surge, because the LH like surges because we have this sudden spike in estrogen. That's like, oh, so then LH spikes. And I actually wanted to mention here, this is what oral contraceptives do. OCPs, you might see them listed as OCPs. This is your birth control pill. Basically all it is estrogen. That's what a birth control pill is. And it's just maintaining estrogen levels at this level. So even if, like no matter what, basically, you're not gonna have an LH surge. And that's why they say it's really important that you take it at the same time every day. You don't miss any days, because if you miss a day and it drops and then you take it that next day, then it's like, oh, estrogen spiked, and then you can potentially have an LH surge. So that's kind of like a cool farm tie-in that like all birth control pills are doing, is keeping estrogen levels high so you can't ovulate. They're basically just stopping ovulation because they're blocking this LH surge. And then this will tie into PCOS. I'll show you how it ties into PCOS when we get there. But does that make sense? So estrogen spikes, boom, LH surge. And then you get your release of the egg and the luteal phase, blah, blah, blah. Okay. And then you'll see here, like too, then progesterone starts to get produced, because remember, progesterone is getting produced from the corpus luteum. But then if there's no pregnancy, the corpus luteum turns into the corpus albicans and it dies, and then progesterone goes back down. And I have seen questions before where they'll show you a graph like this. I don't know about first year. I mean, maybe, but they'll show you a graph like this, and they'll be like, which one of these is progesterone? Which one of these is estrogen? Which one's LH? Which one's FSH? And again, it's kind of going through like what I just kind of went through. Like you need the spike for estrogen, progesterone comes up and then it comes back down. Same with LH. FSH kind of stays low the whole time. But okay. All right. So the theca cells and the granulosa cells, these two cells that are acted on by FSH and LH. So remember, your theca cells are acted on by LH, and then they're going to produce androstenedione. So you can see over here in this first aid image, here is a theca cell in pink, and it's going to get acted on by LH. It binds to its LH receptor, and then you're going to get androstenedione. Granulosa cells are basically like the inner layer of the follicle, and they're getting acted on by FSH, binds to the FSH receptor. And note, I don't know if anyone has mentioned this, but my endo-repro exam first year was huge on the second messenger system, and like what LH receptor is coupled to a G protein. So that's cyclic AMP. So definitely review that. I just wanted to throw that in there. Like definitely review. It was big on like second messengers, G protein coupled receptors, things like that. And like knowing that LH is cyclic AMP is its second messenger, and FSH also cyclic AMP. In first aid, there's like a chart and it helps you memorize which ones are which. But anyway, so FSH binds to its receptor, cyclic AMP gets released, and then it's going to basically convert that androstenedione from the theca cell to basically estrogen at the end of the day. And it uses this enzyme called aromatase. And this is going to come up later when we talk about the androgen insensitivity syndromes later. Just this aromatase enzyme, the whole point of an aromatase enzyme is basically to make estrogen. It's really not important to know the exact, I think, the exact mechanism of what it's doing. It's just making estrogen. Okay, so, but during the menstrual cycle, the granulosa cell is going to convert androstenedione to estrogen via aromatase during the follicular phase of the menstrual cycle. Okay, all right, and this is just kind of, again, how you're getting your estrogen. All right, so all of that to now talk about what happens with polycystic ovarian syndrome, like where did this go wrong? And basically what happens in PCOS, if you can imagine, since we have male pattern hair growth and we have all sorts of weird things happening, there's going to be increased androgen production, okay? So increased androgens, that's what's causing that virilization. That's what's causing that hirsutism. That's what's causing the hair pattern growth and whatnot. So this increased androgen, and from this last slide we just talked about, what were the only androgens we talked about? Androstenedione. And what makes androstenedione? Remember, we talked about LH triggers basically the release of androstenedione. So you can kind of think of PCOS pathophys as there's increased LH and decreased FSH. So I always think of it in terms of like these arrows. It's like LH is way higher than FSH. So it's way, way, way higher, to the point where now we have impaired follicle maturation. So there's not enough FSH to stimulate the follicle properly, so it just doesn't happen. So what happens instead are these follicles, since nothing's happening to them, they just develop cysts on them. And what a cyst is an unruptured ovarian follicle. So we have this big follicle, and then it can't rupture. Nothing can really happen. It can't get chosen because now we don't have FSH to help it mature. So we have these basically like unruptured follicles just all throughout it. And if you look at it, they look like cysts, and that's where it gets its name, polycystic ovarian syndrome. This can lead to infertility because, again, and obviously primary and secondary amenorrhea, usually it's primary amenorrhea because you're usually like born with this, but it can cause secondary amenorrhea. But usually this patient is infertile because there's no way to have ovulation. There's just no way. So the other thing that can happen, and this is kind of just trying to tie in why there might be insulin resistance. They're not actually sure. I don't have a good example for this. But I don't know if you guys have gotten to the point where in Costanzo, when she talks about sex hormone binding globulin, so SHBG, she talks about it like very briefly in one of the Repro sections. So basically, sex hormone binding globulin gets produced by the liver, and it goes around and it binds up like free androgens and free estrogens. It just makes sure everything is kept in check. Basically, you don't have too much. So what happens is they think insulin gets really high in these patients for some reason. Again, they don't know why. I went into a rabbit hole trying to find out why. They have no idea. Insulin increases, and they think this increase in insulin blocks the sex hormone binding globulin, so it can't basically bind up the free androgens and estrogens. So now there's even more androgens and estrogens kind of like floating around. Okay. So here's a picture. So this is kind of like when I think of feedback in the endocrine system, this is what I think of. So remember, hypothalamus releases GnRH, which is going to trigger the anterior pituitary to release FSH and LH. But we're talking about PCOS. So remember PCOS, FSH is basically non-existent. So this is gone. So there's not enough to stimulate granulosa cells. So no granulosa cells are produced here, or they're not stimulated here to make any estrogen at all. LH, though, is really high, tons of LH around, and it's going to trigger the theca cells to release your androstenedione, which is a type of androgen, and now androgens are going to do hirsutism, acne, various things that we have talked about. But remember, there's aromatase in the theca cells, right? Remember that aromatase? So it can actually take some of those androgens. So some of them gets converted over here and you get hirsutism, the male growth, the acne. And then some of it gets converted by aromatase. So this is aromatase. I'll just do aroma. Aromatase converts it to estrogen because remember, aromatase makes estrogen. So now we're making estrogens, and you're like, oh, cool, we fixed the problem. It's not enough estrogen. It's like not enough to kind of make up for not having granulosa cells make estrogen, but it's just enough for a negative feedback. onto the anterior, like onto the hypothalamus basically. And then you can see here, this is obviously a very abnormal negative feedback. So it's going to further promote this LH, this very, very high amounts of LH over that FSH. And then this is just, again, over here saying that they think insulin also plays a role with this. It binds up that sex hormone binding globulin. And so you're going to have even more free androgens that can get converted to the estrogens. Okay, so that's PCOS. And then I have another picture of what the follicles look like. So again, so here is so again, this is like your follicle, right? And remember, they're going to get matured. A bunch of these are happening at once. One gets chosen. This is probably your Graafian follicle right here. It releases its egg. Here's your LH surge. That's what's triggering ovulation. And then it dies. It basically dies. And now this is the corpus luteum. And then the corpus luteum makes progesterone. And then if the woman's not pregnant, it involutes. Now it's the corpus albicans. And then the process starts again the next month. PCOS, LH is so high, there's no LH surge. And if there's no LH surge, we have no ovulation. And so basically all of these little circles are just unruptured follicles. And if you have a bunch of unruptured follicles, those are what cause the cysts in polycystic ovarian syndrome. All right, and then we'll do some questions at the end, and you can kind of see how they word it. It's fairly obvious that they're talking about PCOS. I did want to talk about Turners in this PowerPoint because people really confuse Turners and PCOS sometimes because they can kind of present a little similarly. But the PCOS pathophys, just think of it that LH is way too high. And if LH is way too high, you can kind of figure out all the other things. Like, okay, that's going to cause a lot of androgens. That's not going to cause any LH surge. You're not going to have ovulation. You can kind of work your way through the rest of the symptoms with PCOS. Just remembering that LH is super, super high. All right, good. Relatively painless with PCOS. Okay, so next are the Mullerian duct abnormalities. These are just like your extra points on exams. I think that these are just good to kind of run through. I know they're in the Anki deck, but just actually I think seeing them is helpful. So there's septate. It's basically like talking about the types of uteri that you can have and how they kind of relate this back to phys is it's not really phys. They'll ask a little bit more about embryo. But it's really like repro embryo is kind of important, like in terms of like how does the Mullerian duct form, and this will actually help us with the androgen insensitivities later, like understanding like what all the different parts of the Mullerian duct are and why these form versus the male, like the Wolffian duct and whatnot. All right, so we're gonna talk about these guys. So the most common one is having a septate uterus. There's also a bicornate uterus, and then the uterus didelphys, which is only around 8% of patients. This is usually asymptomatic. I actually have a friend that has one of these. I forget which one she has. She had no idea she had it, like absolutely none. And then it says it's usually asymptomatic before puberty. She really didn't even have symptoms during puberty. Some of the symptoms that they are down here, so like infertility, dyspareunia, and menorrhagia. So dyspareunia is like painful intercourse, and then menorrhagia, this is like the main symptom people say is like having very painful menstrual periods, basically. So that's pretty much it, but she didn't really notice, and then when she went to like a random checkup for her OB-GYN, they're like, yeah, you have 2 uteruses, or like you have one, I forget which one it was. She's like, oh, okay, cool. Which is fine. It's just like, again, they'll tie, like the test questions will tie it into like how does this happen? Like what happens with the Mullerian duct embryology when it's developing, and how you kind of screen for this is just with an ultrasound, and you can confirm it with an MRI. Usually you can just see it on ultrasound and it's fine. So the Mullerian ducts, these are known as your paramesonephric ducts. Definitely know that. Definitely know when you see paramesonephric, they're talking about Mullerian. We're in the female, like think female. These are going to develop from the mesoderm, if the name didn't give it away. And they develop roughly until about the 8th week of development, fetal development. The Mullerian duct, the paramesonephric duct, this is the precursor to female internal sex organs. And this is really important, really, really important, especially when we start talking about the male stuff later with the androgen insensitivity, okay? So the internal sex organs are going to be your fallopian tubes, your uterus, and then the proximal vagina. So remember we talked about this with the anatomy section. It's going to be just like the highest part, like the part of the vagina closest to the cervix, which is the start of the uterus. Okay, so this is your internal sex organs. When they talk about internal, they're talking about these three things, and they're talking about they came from the Mullerian ducts. Okay, differentiation from like, the paramesonephric ducts into these organs is driven by estrogens. In males, if you're a male, you have the Y chromosome, the SRY gene. It's going to suppress the Mullerian duct formation via AMH, anti-Mullerian hormone. Another name for AMH is MIF. I get that question all the time. I actually just get like texts, like, is AMH and MIF the same thing? Yes, they're the same thing. So I think MIF is, I don't even know, Mullerian inhibitory factor or something like that. I actually think I use MIF in like a later slide. They're the same thing, okay? So suppressed by AMH in males. So the whole purpose of secreting AMH, MIF, whatever, is to block the paramesonephric ducts from developing. Because if you're a male, you have the Y chromosome, you don't want internal female sex organs, right? So you need to stop that. If you are a male, so the male is going to secrete AMH, MIF, it's going to stop the Mullerian ducts from forming, but what it's going to do is it's going to degenerate. And when it degenerates, it's going to turn into what's known as the appendix testes. And I should have put a picture in here. I'm sorry I didn't. If you think of the testes, which is just like, the little ball here, the appendix testes, it's literally just like, and you can look a picture of this up online. It's like it literally looks like this. You can think of like the colon, how the appendix is like a little worm-like thing coming off the first part of the colon. It's kind of the same thing. That's why they call it appendix. It's just like a random little appendage just on the testes. That is the degenerated Mullerian duct, because they're not a female, they're a male, so it degenerates. And remember too that when you're born, and that's why that one slide I had from the anatomy session we did is so important, because it's like in the middle is like the unisex, and then it's like if you have these hormones, this is going to develop. If you have estrogen, this is what's going to develop. It's kind of the same idea. So if it's not told that it shouldn't be there, and this is where everyone in my class would joke, like, everyone's born a female. It's true, because like if you're not told, if nothing is told to stop developing, you're automatically going to develop into a female, unless you get AMH, MIF getting secreted. You're going to automatically become a female. Okay. And they think that that's like an evolutionary thing, even though it doesn't really make sense. But regardless, that's what it degenerates into, the appendix testes. It's just a little appendage. So that's kind of what I was talking about. So what I wanted to point out is note that there's two Mullerian ducts, or paramesonephric ducts, whatever. And you can kind of see how they're developing. Like they kind of go, so, and I say note that there are two, like at the very beginning, and they're going to eventually fuse, right? Because if you follow, like, oh, that kind of looks like fallopian tubes, that does turn into fallopian tubes. And then this part, you can kind of start seeing it's going up, and that's what's going to kind of turn into basically where the uterus is. So, and I put note there's two, because if there's a problem with fusion, you can imagine there would be two uteruses, or there would be a septa in between the uterus or something. And that's where these Mullerian duct abnormalities arise. And then you can see the Wolffian duct, which is the mesonephric duct. And then here's the testes here, or the ovaries, if you're a male or female. And then remember, it's the internal female sex organ, so the uterus, fallopian tubes, and then the proximal part of the vagina. Notice that it's only shaded like up until this point, and then the rest switches over to the external. Okay, so then kind of like going into this process more, I don't think it's super, again, I have no idea, but I don't think it's super important to know these steps. I just wanted to show you like, okay, yeah, here's your two paramesonephric ducts. They're going to start kind of like fusing a little bit, and then you're going to get what's starting to look like a uterus, and then you get like your uterus with the canalization of the vagina. And remember, canalization, whenever you see that term, is like tunneling. So we talked about it like briefly with pyloric stenosis. There's no canalization. It's kind of the same thing here, or duodenal atresia. I think that's the one. Duodenal atresia, there was no more canalization of the duodenum. It just stopped. It's kind of the same thing here. That's where we are getting canalization. We're forming a tunnel, basically. Okay, so septate is the first one. The septate, and I kind of put on that slide where this process is going wrong. So the Mullerian ducts will fuse. They completely fuse. So these two guys fuse together. But see how there's this septa here in the middle? And it's kind of like the interventricular septum of the heart. Any septa you can think of. It's just like that doesn't go away, and it should. It should be nice and empty in here, and it's not, and that's your septate uterus. So you can kind of see it's like they fuse, and this looks like a normal uterus, but it has like a septum. This looks like, heart chambers now all of a sudden, and it shouldn't. Okay, so that's septate uterus. And you can kind of see if you were to use like x-ray or do like contrast or something, even an ultrasound, this is kind of how it would look. Here's your normal uterus. It looks like a V. That's kind of what it's, this, whatever dye they gave was like staining for, I don't really know, clinical stuff. But whatever dye they were giving here is just looking at the uterus. So that's what it's looking at here. You can see some of the fallopian tubes over here. And then here you can see there's a septa. Yeah, like a septa right in the middle. So it kind of looks like a heart. This can be as deep or as not deep as necessary. Like this is just one example of them. This can go all the way down. It starts getting trickier with some of the other types, but they should give you enough information that you can figure out which one they're talking about. Okay. All right, so that was septate. Bicornate is basically like how it kind of sounds. I think of bi, and it's like, okay, bi is like they started to fuse, but then they didn't completely fuse the two Mullerian ducts. So where it kind of happens is right here. It's basically before the fusion. So it's a step before the septate uterus. And basically here, it's like, it kind of does look like the septate uterus, but you can see like, it's not just internally where there's a septa. Now it's like, it kind of looks like there's two. Now it's actually looking like both are kind of like indented versus septate, which, let me get rid of the ink, where it's one uterus, but now it's just internally there's a septa. Versus here, it's like it kind of looks like there could be more than, right? It's like it itself is indented, and that's what's causing this septum, basically. So that's called bicornate uterus. And that's how it's going to look on ultrasound, x-ray, whatever this is. Looks kind of similar to septate, honestly. It's just, again, they're going to have to give you a little bit more information to kind of help you figure out which one. And then lastly, we have the uterine didelphys. This is just straight up, there's two, like you have two uteruses. I think this is the one that my friend has, which is the most rare one, which is funny. But didelphys, so again, I think of the di, I think two. And it tells you uterine two, we have two uteri. So there's no duct fusion. So it's kind of like you get to this point and it stops. You have a double uterus, double cervix, double vagina, double everything. Okay, so that's kind of how it looks here. Here's your double uterus, here's your one uterus, here's your one uterus, here's your one cervix, and then here's your one vagina, and then the same thing on the other side. It's kind of wild, honestly. And then this is how it would look. So here's the normal, and again, here's that. So this looks a little bit different from the two of them. You can clearly see, these look like two separate entities, which the other two don't look like this. They look similar, but this one, you can kind of tell that this is uterine didelphys. And I have gotten the question before, like, how does this, like, with my friend, like, how does it kind of affect her life? And I think she told me that her OB-GYN said when she's trying to get pregnant, she might just have a harder time getting pregnant. Or she might be, which this is insane, she might get pregnant with twins, but they're in two separate uteri. Isn't that insane? So she could have a baby from one uterus and then a baby in the other uterus, which is insane. Usually, though, they say that one of the pregnancies won't be viable because it blows up in such, like, it just, the body can't handle both of them at the same time. But isn't that insane? Technically, she can have two because it's like there's two stuff. Wild. But it's only 8% of people, so you probably don't have to worry about that. Okay, and then, yeah, so that was that. Those are your Mullerian duct abnormalities. And now I wanted to kind of go into, like, the mesonephric or the Wolffian duct abnormalities that I think are relevant. So androgen insensitivity, I used to think this was so hard during first year. So we're going to go through it. I would definitely say, though, pick this as an LI or pick, like, your androgen insensitivity syndromes as an LI and really force yourself to learn it, because I, again, thought this was very difficult first year. And if you just kind of sit down with the material, you can kind of work through it. I still think it's kind of difficult, but this is my roadmap to androgen insensitivities, okay? All right, so the main thing to understand, and you'll see with vignettes, it's kind of hard to pick out what's going on with the patient. So with androgen insensitivity, it's really important to understand that the patient is a male. Okay, so they are XY male. And I always put XY male because it's like there's one X chromosome, there's one Y chromosome. Remember, this Y chromosome is what makes it like this person is a male because there's a Y chromosome. Remember, the Y chromosome has this SRY gene, and I always think of it, sorry, you're a guy, right? So SRY gene gets activated. This is what's going to trigger the testes to develop. Okay, so remember, your Y chromosome is going to confer you being a male. It's like the extra step, because if this wasn't here, automatically you're going to be a female, basically. Okay, just default is female. So SRY gets activated, the testes are going to develop. So now that we have testes, we're going to have our Sertoli cells, we're going to have our Leydig cells, we're going to have all those types of cells. Those Sertoli cells are going to secrete MIF. Okay, so remember AMH, same thing. Mullerian inhibitory factor? Yes. Or Mullerian hormone, I think. So it secretes that, and we just talked about this. This is what's going to block your Mullerian ducts from developing. So you can think, another way to think about this is blocking female internal genitalia. So remember, your uterus, your fallopian tubes, and your proximal vagina, okay? That's what MIF, AMH is doing. So with androgen insensitivity syndrome, all of this is happening. So, and if you're thinking about this, it's like, wait, this is fine. Yes, because this is normally what happens, okay? So we're talking about an XY male that has androgen insensitivity syndrome, but you can see up until this point, everything's normal. Y chromosome, testes develop, AMH gets released, no Mullerian duct. So you can already think about it how, okay, there's not going to be female internal genitalia, so there must be male internal genitalia, right? Like something has to be in there. There's got to be something in there. So not female, so it's got to be male. And that's what I have here. This is fine. This is normal. Patient will not develop female internal genitalia. But this is where the androgen insensitivities get confusing, because what happens think about the name, androgen insensitivity. The body is insensitive to androgens. It doesn't care. Androgens are getting secreted. It doesn't care. It doesn't see them. You can think of it like that. So the Leydig cells will secrete testosterone. Remember, Leydig cells get acted on by LH, and then they secrete testosterone. However, since this is androgen insensitivity syndrome, the body does not respond to that testosterone. So the Leydig cells can secrete all the testosterone that they want. It doesn't matter. And if you're sitting there like, oh, that's probably not good, you have a male with no testosterone, you're 100% correct. This is the issue. This is the issue. And this is, again, where vignettes get tricky. And I did bring in a bunch of vignettes so you can see how they word androgen insensitivity, because it's super confusing sometimes, especially when you line it up with some of the other pathologies in this block. It can get kind of confusing. All right, so we're continuing. So we still have our XY male, not female internal genitalia. We have male internal genitalia, but now remember, there's no testosterone. Like, there's testosterone being released, but it's not, the body's not responding to it. So let's go back. Remember, MIF gets released. So MIF is going to block the female development. Cool, that's normal. But another thing that MIF does is it basically allows those Wolffian ducts, those mesonephric ducts, to develop. That's going to develop into your internal male genitalia. And I have here, and I have the picture that you should 100% memorize from first aid on the next slide. But so we'll do that in a second. So remember that MIF helps with Wolffian duct development. As soon as that's there, those Wolffian ducts are going to develop. Testosterone does help with this process. I think on the image, there's like a testosterone with a plus sign. It's like, oh yeah, it's helping with that process. It only helps, though, with internal male genitalia formation. And this is kind of what I was saying earlier, is yeah, even though the body's not responding to that testosterone, you're still getting the Wolffian ducts developing because of this MIF, which again is normal, because again, we're good up until this point. So it's still getting that MIF, so the Wolffian ducts are still developing, so you're gonna get internal male genitalia. People always get this confused. So androgen insensitivity is gonna be internal male genitalia. And if they're like, well, testosterone, they're not responding to testosterone, it's okay. You don't really need, you don't need it to have your internal male genitalia. It only helps with it. You really need your Wolffian duct to develop. And to have your Wolffian duct to develop, we need to stop the default, which is the paramesonephric ducts, those Mullerian ducts, from developing. How do you do that? MIF. How does MIF get secreted? Sertoli cells. Where do Sertoli cells come from? The testes. And you need the testes come from having an SRY gene, which comes from the Y chromosome. See all the physio? Yeah, so that's kind of how you're able to still have this male with internal male genitalia. And you'll see I'm emphasizing this because, again, how they're going to word this in vignettes is they're going to say it's a 17-year-old female comes in. And you're going to get all sorts of confused. Because as you can imagine, externally, they're going to look female because the body's not responding to testosterone. Okay, so we're good with the internal stuff. I wanted to show you this chart. 100% must memorize this chart. This chart will come up all the time. This is kind of the chart that I think of when it's like they talk about androgen insensitivity, 5-alpha reductase deficiency. That's another one. And just asking about, the various development pathways for the internal and external male and female genitalia. Okay, so we talked about all this. So over here, this is what I was kind of mentioning. Here's your mesonephric Wolffian duct. This is going to develop because MIF is shutting off the development of the paramesonephric ducts. So that's going to shut down this default pathway. So now this can just, second choice. It can just start to develop. That's fine. It's going to develop into your internal male genitalia. And remember, testosterone only helps. It's not required at all. Like testosterone is not at all required to make this internal male genitalia. It's really, you just need the Wolffian duct. And then definitely know what counts as internal male genitalia. I think I might have mentioned this last week, but I don't remember, or last session. So your internal male genitalia is going to be your seminal vesicle. That's kind of where all the that's where all the Sertoli cells and whatnot are. Your epididymis, ejaculatory duct, and vas deferens or ductus deferens, same thing. That's going to be your internal. Your external is going to be the penis, scrotum, and prostate. Okay. So we're only talking about this as of right now. We've only been talking about internal as of right now, okay? Because again, external gets confusing. So internal for your androgen insensitivity, they're internally a male because they're internally this pathway. All right, so where does it get confusing? It gets confusing with the external. So again, we're here, internal genitalia is male. I'll come back to this little bullet here. Externally, they're going to be female, and this is where I'm telling you, even write a little note here, and you'll see this with some of the questions at the end. They're going to say a 17-year-old female comes in for a checkup. They're not a female. It's not a female. It's a male that just has external female genitalia because there's no testosterone. All right, and this is where kind of like if externally they look like a female and they come in, sometimes this kind of helps you figure out that they're getting at androgen insensitivity. They'll mention there's an inguinal mass. They're like, oh, this female has inguinal masses. And you're like, oh, it's a hernia. It's not a hernia. It's just those testes that haven't descended yet. Okay, because again, they're male. Like it's male, so it should be there. They're there. They weren't able to descend. These are just like little things to look for in the vignettes. All right, so why is the external genitalia female if we have an XY male? The body here is not responding to the androgens. Again, so this is going to include testosterone and DHT, dihydrotestosterone. And if I go back, remember testosterone gets converted via 5-alpha reductase to dihydrotestosterone. And remember, DHT is what's responsible for external male genitalia. Everyone wants to say testosterone is responsible for external, and it's DHT. And it's a really big what am I trying to say? It's like you should know that. Like you should know DHT is what's responsible for external. Testosterone is responsible, quote unquote, responsible for internal, versus estrogen is responsible for both internal and external. It like contributes to both. But it's DHT specifically which contributes to your external. And I only mention this specifically because androgen insensitivity gets compared a lot to 5-alpha reductase deficiency, and that's why. It's because in 5-alpha reductase deficiency, there's no DHT. So you can imagine, like, it's gonna present very similarly to androgen insensitivity. But I have a slide, like, how can you tell the difference between the two? Okay, yes, so DHT, so body, remember, androgen insensitivity, it's not responding to any androgens, testosterone, DHT. No DHT, no external genitalia, okay? And then the body is then converting the excess testosterone to estrogen. What's the enzyme that does that? Aromatase. So remember, it's kind of similar to what we were talking about with PCOS. All right, we're just going to call it aroma. All right, so aromatase is going to convert that excess testosterone to estrogen. So now there's tons of estrogen being produced in this male. So you can imagine that can contribute to your female external genitalia. So there will be like breasts. It's pretty much it. Like there's gonna, breast. Oh yeah, that's the other thing. They'll say like the vagina will end in a blind pouch, because it's kind of like externally, like the distal, like there is part of the vagina that is responding to this estrogen being made. But remember, the proximal vagina is technically internal female genitalia. So all of a sudden, this vagina just like ends in a blind pouch. That's like how they'll word it. It just stops. And again, it's because they're not really a female, they're a male, and they have male internal genitalia. So, but if you would look at someone, you'd be like, oh yeah, you're a female, right? Like you have breasts, you look like you have female external genitalia, but internally they're a male. Okay, all right. And then finally, how can you tell the difference between this and 5-alpha reductase deficiency? In 5-alpha reductase deficiency, there's no breasts that are developed, none whatsoever. And then you get virilization at the time of puberty. So virilization is kind of like, you can think of this as like we kind of mentioned it with like the PCOS stuff. It's like you have like male features. That's virilization. And the reason this occurs at the time of puberty, it's really interesting actually. You have a burst of testosterone at puberty. Males do. They have this burst of testosterone, and like that's what's going to kind of like, it's going to be enough to kind of overtake. I don't remember exactly. I do remember, I think it's like there's enough that it can overtake the DHT, or it can like almost force DHT to be formed, and then you can have this external male genitalia. Don't quote me on that. But this is the two ways you can kind of tell the difference. Versus androgen insensitivity, there's not going to be virilization at the time of puberty. They're still going to look like a female on the outside, like no matter what. And then there is going to be breast development with androgen insensitivity, because all that testosterone is getting converted to estrogen. Here, that's not happening. It's just not enough to do that. All right, so those are kind of the two ways to tell the difference between that. But androgen insensitivity, memorize this chart, learn this chart, love this chart, kind of make sure you can walk through it. And we'll do, at least, if we don't do all the questions at the end, at least I'll bring up the androgen insensitivity questions so you can see how it's worded. Okay. So sex chromosome disorders, specifically focusing on Klinefelters and Turners. Like I said, Turners, they love to ask about, especially compared to PCOS. So I wanted to be sure to include that. So I wanted to talk about mitosis meiosis very briefly. I know people hate mitosis meiosis. I promise I kept it exam relevant. It's no PhD level, I promise. So the first thing to kind of keep in as a review is, and I know we all had, like everyone had this in college at some point, but they will ask it. You will get mitosis meiosis on boards, shockingly. So if this is what they show you, here's a cell, and mitosis, remember, we're just taking one cell, we're splitting it. So terminology, I tried to label this. So we have 2N, and you can think of N as number of complete chromosomes. That's your N. So here's one complete chromosome. Here's 2. This is their second complete chromosome. And then we have 4C. Sorry. Got super excited about mitosis. The C, you can think of C as being DNA content. So I know people say like, oh, sister chromatids or chromatids, and I think that's super confusing. So I think of it as complete chromosomes for the N, and then C is, think of it for content. So here's one DNA content here, second here, third one here, fourth one here. And all you're pretty much doing in mitosis is you want to get one from this chromosome and one from this chromosome, split them, and then one from this one and one from that one, split them. So when you go through mitosis, you're going from 2N4C to 2N2C. So we have 2 complete chromosomes. Remember, chromosomes, you just need that's why chromosome is so confusing. Is you just need one of these little guys. So we have 2N again, but now we have only 2C because we only have like a half of a chromosome, basically. We have half of the DNA content because we split it. Okay, that's mitosis. It's like hard to explain it not at a super high level that I've just been doing for so long in the PhD. Okay, so anyway, that's mitosis, and now meiosis is when you start getting that crossing over stuff. So it's the same thing. We have 2N4C. We're starting with 2N4C. You can think of this as one from mom, one from dad. Meiosis 1, and it's important to remember that there's 2 stages of meiosis, and we'll talk about why, because in some of the sex chromosome disorders, it's oh, this happens in meiosis 1, or oh, this happens in meiosis 2. So you can kind of visualize where that's happening. Remember, there's crossing over at some point. So part the second sister chromatid of moms crosses over with the first sister chromatid of dads, and now we have this cross, and now we split them. So meiosis 1, we're just separating the complete chromosomes. So we have now just N, so 2N4C to N and 2C. And then meiosis 2 is now we want just one sister chromatid into each like cell, basically. So then we go from N2C to NC, and we have 4 of those. All right? That's the base. That is the amount you need to know, I promise. And this is kind of where it comes up in terms of like repro and why it's relevant for this block. And you can kind of follow along like, oh, we're 2N2C, then we're 2N4C, 1N2C. So kind of like going through that. Remember, N is going to be your total, like your complete chromosomes. And then C, just think of it as DNA content. Definitely know that it's 46 to start, and then it, as it goes through, mitosis is going to be 46 because it's 23 from mom and 23 from dad, and this is complete sets of chromosomes. And then you're going to, and that's also why it's 2N, because it's 2 times 23. And then once you go through mitosis, once you go through meiosis, that's when everything starts splitting, basically. Okay, so we have our 1 round of meiosis. We're separating the complete chromosomes, and then you separate them so you can get 4. And then we talked about this last time. This is spermiogenesis. This is when you get the acrosome, the head, and all that stuff of the mature spermatozoon. Nothing too earth-shattering about male like mitosis, meiosis. Female, I put on here. I put where you're going to get your questions, for sure. They're going to ask this. So it's kind of the same thing. So we have 46 chromosomes again. So we have 46 single chromosomes. So we're 2N2C, same thing, same nonsense. We do mitosis. We're still at your 46 sister chromatids. So we did reduce our N number, but whatever. Okay, and then here's what's really interesting. This, after it undergoes mitosis, this egg, basically, is going to be arrested in prophase 1 until ovulation. Okay? It's weird. It's super odd. It's just, you need to know it. So you kind of need to know that this ovum, this egg, is going to be arrested in prophase 1 until ovulation. So people remember like prophase till ovulation. And yes, this is during puberty. So this is as it's developing, which is super interesting. The egg is going to stop in prophase 1 of meiosis 1, right? So prophase 1 of meiosis 1, all the way until puberty, until the first egg gets released ever. It's that egg that got arrested in prophase 1. So weird. All right, and then you have to undergo, so we have meiosis 1, we separated the complete chromosomes, and now we undergo meiosis 2, which is now where we want to separate into like all 4 sister chromatids, basically, into their own cells. But remember, in eggs, you only make 1, and then you get 3 polar bodies. If you didn't know that, that's just what happens. 3 of the so-called eggs turn into polar bodies. You only get 1 like functional egg. But what's interesting too, so after puberty, the egg is going to, you're going to have ovulation, the egg's going to get released. It's not going to be like going through the rest of meiosis during that release. It's actually going to stay. It's going to get to metaphase 2, so it's going to go through prophase 1, it's going to go through the rest of meiosis. It's eventually going to get to metaphase 2, and then it stops again. It gets arrested. It gets arrested in metaphase 2. And the only time it would get unarrested or allowed to continue on is if fertilization occurs. So how people remember this is metaphase 2 till an egg met a sperm, which is fertilization. And there's all sorts of like theories why this happens. They think it's just so, the egg is very mature, or it's only released when it should be released, or they don't really know why this process happens, why they do get arrested. But I think it's like kind of like quality control in a way. But just definitely know just have these memorized. Like the egg gets arrested, prophase 1, prophase 1, meiosis 1 until ovulation, and then metaphase 2 of meiosis 2 until fertilization. All right. Okay. All right. So then other sex chromosome disorders that you can think of, these are called aneuploidies. So aneuploidy in general just means an abnormal chromosome number. So abnormal can mean there's an extra one, or there's a missing one, or there's multiple extra ones. and multiple missing ones. So some examples of aneuploidy are disomy. So disomy, there's 2 copies of a chromosome. Monosomy, so there's only one copy when there should be 2, or trisomy. So this is like the classic one that people know, like of your trisomy. There's going to be 3 copies of a chromosome. So the question becomes like, how does this happen? Like, how do you have like one of these aneuploidy things? Usually it occurs during meiosis, and there's a process called non-disjunction. So non-disjunction is exactly how it sounds. Like, I think of like so disjunction, it's like separating, right? Non-disjunction is like there's no separation, and it happens during meiosis. So you can have meiosis 1 non-disjunction, or you can have meiosis 2 non-disjunction. It just means like you're not getting the chromosomes are separate. You're not getting chromosomal separation in where they should be happening in meiosis 1 or meiosis 2. This is the most common type. There are multiple types, you probably will have to learn those eventually when you start studying for boards. I did get like UWorld questions on them. I don't remember if I got them on boards, but I was getting UWorld questions on these different types of like issues. But the most common one, I thought we could just keep it at this for now, is meiotic non-disjunction. You might have heard of like, Robertsonian translocations. That's another one, like various types, like that's all other ways that this can happen. But meiotic non-disjunction is like the most common way that you can get an aneuploidy. So a monosomy, disomy, or a trisomy. And then, yes, it can happen in meiosis 1 or meiosis 2. So here is kind of like where non-disjunction would occur. So see here how we didn't get separation of the 2 complete chromosomes here. So this would be non-disjunction of meiosis 1. But you can also have non-disjunction of meiosis 2 over here, which is where the 2 chromosomes separate, no problem in meiosis 1. But now in meiosis 2, when we want to separate into the 4 cells, one of these sister chromatids does not get separated. So that's non-disjunction. And you can kind of like follow this down and see like, oh, here's how you get 2 cells that have trisomy and 2 cells with monosomy. Oh my God. And then over here in meiosis 2, you get 1 cell with trisomy, 1 with monosomy, and then 2 completely normal. So it does look like non-disjunction meiosis 1 is a lot worse, because at least in meiosis 2, you would have the chance of having 2 normal gametes, potentially. But in meiosis 1, none of the gametes will be normal, unfortunately. Okay, so I have seen questions like that. Well, they'll even ask, like, here's what the cells look like, the gamete cells look like. Where did the non-disjunction occur? So you can kind of like work your way back and try and figure it out, but I would just have these 2 in mind, at least. Non-disjunction of meiosis 1 and meiosis 2. This is from, I know it's a little blurry, but this is from Boards and Beyond. I just kind of I would have just drawn this, but I'm like, I'll just screenshot it, right? So this is kind of the same thing. So we talked about meiosis 1 non-disjunction. You don't get separation of the complete chromosomes. So you can see the gametes, they should just be N. Now we have N plus 1, N plus 1, and then N minus 1, N minus 1. Not good. Over here, non-disjunction meiosis 2, separation of the complete chromosomes is fine, but now we have one of these cells has an issue with the sister chromatids failing to spread. So this is normal, this is normal, this is N plus 1, and now that we have an N minus 1. So you can kind of, again, it's kind of like a map. You can figure out like where the non-disjunction occurred. Okay, so that's how you can get aneuploidy. So that's, again, just various types of mitosis, meiosis, non-disjunction, and then kind of keep it going. So if you think of sex chromosome disorders, you can think of aneuploidy is one of them. We just talked about it. Those are your meiotic non-disjunctions. More commonly, you'll see Klinefelter's and Turner syndrome. So we'll go into those. There's also some other ones. They are in first aid. They probably will come up at some point, but they're not as common as Klinefelter's and Turner's. This is going to be your double Y males and something called ovotesticular disorder. Again, they're both in first aid. There's not even a paragraph about them. But Klinefelter's and Turner's is where I kind of wanted to focus most of this because it's important. All right, so Klinefelters, these are going to be your males. So this is going to be your male, but you can notice that there's an aneuploidy here because now this patient, the male, has 47 chromosomes, so he has a trisomy, and he has an XXY genome. So he is an XY male, but he's got an extra X chromosome. So he probably had like one of these he either had, meiosis 1 non-disjunction, or he could have had one of these meiosis 2 non-disjunctions, but he's one of these guys. And he has 2 X's and then 1 Y. So if the X is the green, he's got 2 of those and then 1 orange Y. So that's how that can happen. That's how Klinefelters can happen. Again, like I said, it doesn't just have to be meiotic non-disjunction. There's a bunch of other types of, causes of aneuploidy, but that's the most common one. So you can think of what would having an extra X chromosome look like. It would kind of be exactly what's on this image. And that's kind of why I put this image here, to kind of get a visual of how a Turner's male would look. And again, notice right off the bat that this is going to look a little bit different from like your androgen insensitivity. This is going to be like, they know they're a male, so they are going to have, your male external genitalia. It is going to be a little bit smaller, but they are going to have that male external genitalia. So they know they're a male. Like it's not obvious, but like it's like, oh yeah, they're a male, but they're going to have breast developing. They kind of have like female features. So some things like female type pubic hair pattern distribution, wider hips, which is normal, like more commonly in females, for birthing. They also have long arms and long legs. Don't know why, but they do. And then they have like the tendency to grow fewer chest hairs. So remember we talked about like hirsutism. This is like the opposite of hirsutism. It's like they're not having that male pattern growth. So they have poor beard growth, fewer chest hairs, back hairs, things like that, more narrow shoulders. So that's kind of like what this extra X chromosome is like contributing to, but it's all kind of things that you're like, oh yeah, that makes sense. That's what an extra X chromosome would lead to. Having breast development, by the way, I don't know if you've heard this term before, but gynecomastia, that just means like you're developing breasts. If you're a male, that's gynecomastia. They also will present with a developmental delay. A lot of the times with any form of aneuploidy, there will be a developmental delay. And how you'll kind of like diagnose Klinefelters is you're working up hypogonadism. So you're kind of trying to wonder why, like maybe the testicles didn't drop when they should have. Or the testicles are just small. Maybe they did drop, but they're really small. So you're trying to figure out, and that's what hypogonadism is. So the gonad, the testicles, hypo. So they're small, they're not developed, and you're trying to work that up. Like, why is this happening? So going into the physio, before we go into the pathophysio of this is all stuff we kind of talked about with the anatomy, like in the histo part of the anatomy. So remember, with Klinefelters, since we do have that extra X chromosome, the seminiferous tubules are not going to work correctly. They're just not. They're like, they get confused. They're like, I don't really know. So they're not working properly. That's kind of like the underlying basis of Klinefelters. So you can think of this, if your seminiferous tubules aren't working correctly, you're going to have decreased levels of inhibin B. So here's inhibin B, which again gets released from your Sertoli cells. And if we have decreased inhibin B, we're going to have increased FSH, right? Because remember, and we talked about this very briefly last time, FSH gets released, it's going to act on the Sertoli cells to secrete inhibin B, and then that's going to inhibit itself. It's like doing negative feedback on itself, so you don't get as much FSH being released if you don't need it. In this instance, we don't have as much inhibin B because the seminiferous tubule itself is just not working properly, so more FSH gets released, okay? So that's the first thing that happens. Then the Leydig cells are not forming correctly. Remember, the Leydig cells are kind of the ones like along the sides. They're like on the outsides of the seminiferous tubules. Those normally secrete testosterone. So they're not forming correctly. You get decreased testosterone, which is going to, again, no negative feedback on LH. So we're going to have elevated LH. And then you can have increased estrogen. And the reason you get your increased estrogen is because the testosterone that does get made can get converted to estrogen. Why does this still happen if bar body formation occurs? Do you mean with Klinefelters? Or do you mean? I see what you're saying. No, that's why Klinefelters is pretty rare. Because I think what you're asking, and correct me if I'm wrong, is when you're developing and you have the bar body that forms, which is kind of like the polar body here, it needs to be in the one that's chosen. I know this is in females, but it's kind of the same idea. Even with the male, it's kind of the same idea. It's like it needs to be the one that gets developed is the one that has that trisomy or aneuploidy issue. So if you're saying that this is like bar body, bar body, bar body, then no, you won't have Klinefelters. It would only be this one. That's a good question. Bar body or polar body, you can kind of think of it as like it's out. It does not contribute. It's not a thing anymore. That's why this is like kind of rare. And I also think that's why with the gametes, we only have one that's basically developed. That's why only one kind of develops, is because of the fact that 3 of them get turned into bar bodies. So if on the converse, if you have a meiotic 2 non-disjunction, and let's say these 3 are bar bodies, you would have absolutely no idea. Like, you'd never know. You'd be none the wiser. And it would be totally fine. It would just be like one of those very unlucky things that it would be like the opposite. Like, these 3 are your bar bodies, and now you're like, cool. And now you can potentially have Klinefelters. And again, this is meiotic non-disjunction, so that's why we're talking about X and Y chromosomes. So that's again why this would contribute to that versus like, like trisomy 21 or something that's not talking about one of the X and Y chromosomes. It's talking about Down syndrome, if that makes sense. Oh, X inactivation in each cell. Yeah, I mean, that's also so X inactivation. Why does this still happen if bar body formation occurs? X inactivation more so happens in your somatic cells. I don't believe you need to go into that level of detail. But yeah, X inactivation, it's why why certain types of cats are like multiple colors. It's because some cells are black and some are orange and some are white, so it looks like this really pretty cat. But I'm pretty sure X inactivation happens in your somatic cells. I don't believe it happens in your gametes. So it would be more so this process. Like, it would just be the exact type of cell that gets chosen would not be the one that was turned into like a polar body or a bar body. I believe. I'm pretty sure you don't get that in the gametes. I could be wrong. I'll look into it more. I'll look into it. And I will email you your name. Yeah, I love when like science is like, oh, that's why cats are different colors. It's like, oh, like I'm learning science, but then it's like, oh, who wants to hear about cats being different colors? I'll tell you all about X inactivation. Okay. All right, cool. Do we finish this? Yes. Okay. So basically, Klinefelter's physio or pathophysio is that the seminiferous tubules are not working correctly, and all the cells that are normally male cells are not working correctly. So we're getting weird levels. So FSH is elevated, LH is elevated. Oh yeah, so that's like sometimes they'll like ask about certain findings, and then you can see increased estrogen, and that's what's leading to the gynecomastia, the female pattern growth, and things like that. I always get this question with Klinefelters is like, why is there increased aromatase and estradiol? So why is there increased estrogen, basically, like literally this part right here? And so if we kind of work through this again, if we have decreased inhibin B, so decrease in inhibin B, we're going to have elevated FSH. I'm going to keep flipping back and forth just to kind of show you. So decrease inhibin B, which just happens normally because the seminiferous tubules are just weird and the Sertoli cells are acting weird. Decrease inhibin B, there's no negative feedback, so we're going to have elevated FSH, okay? FSH is going to stimulate the Sertoli cells. Okay. FSH is going to stimulate these Sertoli cells, so the Sertoli cells are still getting activated. And then the Sertoli cells are then going to convert testosterone to estradiol via aromatase. So this is, if you go back to the anatomy PowerPoint I have, like that's where the conversion of testosterone to estrogen is happening, is within the Sertoli cells. So that can happen there. So that's how you can get, and that's why I kind of mentioned earlier that you have that aromatase still, it's still there, so you can actually get that conversion and get elevated estrogen here. And then it's kind of being contributed also by the Leydig cells. The Leydig cells are decreasing testosterone, which is increasing LH, which is just acting on those Leydig cells, which is, then making testosterone, but then it's just going to get converted to estrogen. So it's just, you're kind of like flooding this male with estrogen. So that's why it's kind of like internally they're a male, and even externally to an extent they're a male, but overwhelmingly they look female. And that's Klinefelter's. And again, usually there's going to be some sort of indication that it is going to be like an aneuploidy. They'll talk about like, a developmental delay or something of that sort. So you can kind of figure out the difference between this and like aromatase deficiency or androgen insensitivity syndrome. Okay. All right. And then next is Turner's. So Turner's, they love Turner's. Always ask about Turner's. Turner's, again, gets commonly asked about, like people commonly get Turner's and PCOS confused when they talk about the physiology. Like externally and like physically, they don't look similar. They don't present similarly. But when they talk about the physio, people get kind of confused. And the reason why is because Turner's, I'm going to jump down, is the most common cause of primary amenorrhea. And remember, like I said, PCOS is a workup for primary amenorrhea. And remember, primary amenorrhea is going to be you never get your period. You're a female, you've never gotten your period. You should have gotten your period, you never did. That's going to be the most common cause of it. In Turner's, this is also going to be a type of aneuploidy, but now it's not a trisomy, it's a mysomy, or I think it's mysomy. So it's instead of having 46 chromosomes, they're going to have 45, and then it's going to be XO. So it's not going to be XX, it's not going to be XY, it's going to be XO. So now it's kind of like thinking like, okay, with Turner's, what would not having an extra X chromosome lead to? And some of the most obvious one would be streak ovaries. Streak ovaries is kind of like the ovaries physically don't have follicles in them, which is really upsetting. So it's kind of like this is primary amenorrhea. You can never, like with PCOS, you can at least treat it and hopefully get them on like a normal like life, basically, like where they can have menstrual cycles and get pregnant. Turner's, they can't do that. They have streak ovaries. There's like the ovaries don't contain working follicles. Other physical features of Turner's is short stature, a shield chest, which I think is them just trying to say like it's like big and like broad, like if they had a shield on. Bicuspid aortic, so they have some various types of cardiac abnormalities. Bicuspid aortic valve comes up, but way more frequently is coarctation of the aorta. So I actually think there was a question that I gave you guys back in cardio, and it was a coarctation question, and the question had nothing to do with Turner's, but I think it was a Turner's patient in the vignette, and they were describing a Turner's patient, but then they ultimately asked about coarctation. That happens all the time. So they all, like, I got to the point when I was studying for boards where if I was starting to read like these features of Turner's, I was like, oh, they're going to ask about coarctation of the aorta. Like they go hand in hand, honestly. Like it's so common. So just look for that. Or if it's like if they mention coarctation and it sounds like a weird kind of presentation of a patient, be like, oh, this might be Turner's. Okay. It comes up a lot. A webbed neck or a cystic hygroma. So webbing of the neck just means like it's widened, as you can see here. And a cystic hygroma is kind of like this fluid-filled sac that can be in like the back of the neck. You can also have horseshoe kidney. So remember horseshoe kidney from renal anatomy. The kidney gets stuck on the IMA. When it's trying to ascend, it gets stuck. So then on the x-ray, it looks like a horseshoe. You can have a high arched palate, so like in the mouth, and then shortened fourth metacarpals, which are your fingers, so your fourth finger. And then this is also going to be your most common cause of primary amenorrhea. And then I don't know if I said short stature, but also short stature. All right. So with Turner's, think of Turner's as being menopause before menarche. And I really want to emphasize this, menopause before menarche, because remember with PCOS, LH is high, FSH is not, but LH is high. And I think the fact that LH is high in both of them kind of throw people off a little bit. But if you think of this as being like menopause before menarche, what's more specific for menopause is an elevated FSH. This is very specific for menopause. And the reason why is because menopause is essentially you're losing estrogen. You just don't have any more estrogen. It's gone. That's why it's like you can't get pregnant. That's why you have hot flashes. Like that's why you have all these sorts of issues because you don't have estrogen anymore. If you don't have estrogen anymore, there's no negative feedback on the anterior pituitary, and now there's nothing blocking the release of FSH. So we have tons and tons and tons of FSH, and that's like a fact. That's like a way to diagnose menopause in someone. Is you look at their FSH levels, and if it's really high, you're like, oh, you're in menopause. Like that's why you're having these symptoms. Like let's put you on a bone strengthener because fun fact, estrogen makes your bones really strong. That's why postmenopausal women also have osteoporosis a lot of the time. But anyway, so that's specific for menopause. So Turner's, you're going to have elevated LH and FSH, but the elevated FSH is going to be way more, I guess, telling for Turner's compared to PCOS. And I even put down here, this is compared to PCOS, which is only elevated LH. FSH is low. This is both, but again, FSH is going to be like kind of like making this sentence true: menopause before menarche. So it's kind of like the whole idea of Turner's is like before they even have their first period, which is menarche, your very first period, before they even have that, they're already in menopause, and it's because their FSH is so high. And again, nothing can fix this. There's not like with PCOS, you can put them on a birth control pill and kind of try and level out their estrogen levels, like in a way to kind of mimic, surges and whatnot. Like there's a whole way you can kind of treat PCOS. You can't treat Turner's. It's kind of like they have those streak ovaries. They can never have their period. They can never get pregnant, unfortunately. Okay. Okay. All right. And then just going to the, I think this is the last thing before we do questions. And we won't do all the questions. There's a lot. I also put a lot of questions in there for you guys, and do them on your own. I know a lot of people like to do them on their own, but again, like I said, we're doing an androgen insensitivity one for sure. We're doing one. But for this was on your study guide. I will say, I wouldn't be like super crazy about like knowing every detail of this. You're going to get a lot of this information when you do sketchy during second year. I know that Dr. Janora is trying to incorporate more micro during first year. That's been a lot of the feedback that she's been getting from students over the past like 4 years, is to do more micro during first year. But if something isn't sitting well with you or resonating with you, even just go see if you can go watch a sketchy on it. Micro is a lot of memorization. So especially with these STIs, you're going to keep getting it over and over and over again, okay? Torch infections, those should be pretty straightforward because it's only 3-4 bugs you have to know. But STIs are a little trickier, but just know that you're going to keep getting them over and over and over again, okay? And let me know if you have any questions about micro. I love micro. I think it's so interesting. Okay. So the first one, so this is going to be your STIs, or I should have worded this better. It's like STIs or like issues from pregnant to like a pregnant woman to a fetus. Like, okay. So the first one is going to be group B streptococcus or GBS. And I put here, like, is this a problem for mom? Like if you have it while she's pregnant, or is it going to be a problem for the fetus? And this is going to be a problem for the fetus. I put a gram stain over here. I've put some gram stains in some slides before. So gram stain, this is purple. So you can see these purple things here. That means it's gram positive because they're purple. And you can see they're in chains. So that's a strep. And you can't tell what strep it is, but you know it's a strep because there's all these really long purple chains. So you're like, okay, that's gram positive. In chains, that's going to be a strep. So this is group B strep. The other name for this is Streptococcus agalactiae. This is the most common cause of life-threatening infections in newborns. So this is actually screened for before delivery in every single pregnant mother because it's a really easy fix. You can just give an antibiotic. Normally, it's just found it's a normal flora of the mom's vagina and rectum. It's normally there. So why is it bad? It's transmitted intrapartum, which basically means as the mom is delivering the baby, she can give it to the baby. So it's intrapartum. It's during delivery. If the baby gets it from mom during delivery, it can die, basically. So it can be a stillbirth. It can develop cystitis, which is like a bladder infection, amnionitis, so the amniotic cavity can swell, endometriitis, so the endometrial cavity can get infectious, and you can kind of see here that's what's happening. So it can kind of like infiltrate here, and then it's going to cause issues during for the baby once it's born. And so the CDC makes it require that all pregnant women get screened like right before their due date, because if they are positive, they can just give an antibiotic and then they're fine. Okay. So that's the first kind of one to look out for in like pregnant women. I just thought this was interesting. Like after they started their screening, you can kind of see that cases started dropping like insanely, like a lot, like as soon, like, so around 1992, it went from like, like around like 1.5 births now to like less than a half of births per 1,000 live births, which is good. And it's just like they do this swab, they swab it and they see if they can grow GBS. But I wanted to show like it is a part of the normal flora. So they screen the vagina as well as the anus because it's normal flora of that area. Again, just interesting. I also put on here UTIs in general. I know I didn't really talk about any UTIs, but I wanted to at least put them on here because they can be a problem for mom and the fetus because they can lead to pyelonephritis and premature labor, blah, blah, blah. And you're more prone when pregnant because of the hormonal changes and whatnot. So one of the things is like if you're pregnant, you should be screened at least once for UTIs, even if you don't have symptoms. So that's why it can lead to issues in the fetus. All right. The next one is Listeria monocytogenes. So this is why they tell pregnant women don't eat soft cheeses. You might have heard that before, or deli meats, or have unpasteurized milk. It's because of Listeria. Listeria looks very similar to group B strep or strep agalactiae, the one we just talked about. It's almost always going to be soft cheeses, deli meat, stuff like that. Same thing, intrapartum, so it gets transmitted intrapartumly. The mom can have an asymptomatic infection or she can have a symptomatic infection. It's just going to be like she has the flu. The fetus, though, this is why they screen for it, is you can have amnionitis. Same thing as like group B strep. Honestly, amnionitis, spontaneous septic abortion, so like a stillbirth, premature labor, and then the baby comes out and is infected. But if you ever see that, like the soft cheese, like if you know anyone that's pregnant, be like, you can't have any soft cheeses or deli meats because of Listeria. All right, so those are just, they're not really like STIs, but they're just things to screen for in pregnant women. Like those always get screened for. I used to work in a micro lab and it's like I was constantly swabbing for Listeria and group B strep, like always, because they just do it all the time in pregnant women. Okay, so syphilis. So this is one of the UTIs. No, it's not. It's one of the STIs. Maybe I keep saying UTIs. Sorry, STIs. We're talking about sexually transmitted infections. The causative agent of syphilis is Treponema pallidum. So you might see that as T. pallidum or whatever. It's a spirochete, meaning it's spiral. So you can see it's spiral. This is not a gram stain. You can't see it with a gram stain. So they do a silver stain. And it really just looks like this. It's a spiral-shaped bacteria. If you have syphilis, either primary or secondary syphilis, you'll go into syphilis in a lot more detail. Like I said, the whole point of this is not to teach micro. I just wanted to give you a snapshot because of your it was on your syllabus. So you'll go into syllabus. There's like 3 stages of syphilis: primary, secondary, and tertiary. So they're just saying if you don't treat it during the primary, secondary phase, fetal infection rate is 100%. So it's like if you mom have syphilis, you will 100% give it to your baby. And then it's like if you give it to the fetus. If you give it to the fetus, they can have a stillbirth, they can have a late abortion, neonatal disease, death, or the baby can be born with syphilis, which is terrifying. So this can happen just normally. It doesn't have to, I know I have intrapartum here. It can also just happen when the fetus is developing. So you can see this picture here. They drew the little green squigglies on this. You can see it can pass through the placenta. So it can pass through the placenta, just go to and just infect the baby. And that's what happened. That's when these things happen. If for some reason the baby does not, or the fetus as it's developing does not get the syphilis infection, it will 100% get it when it's being born during the process of labor, so intrapartumly, and then they're going to be born with what's known as congenital syphilis, and it's basically syphilis now in a baby. It's really bad. It's not good, and they have the symptoms of syphilis. So what you do is you test all pregnant women at the very first visit. Does not matter. You test them first visit, you test them for it. And then if you have a high risk woman, so someone that might be engaging in risky sexual behaviors or something like that, the doctor kind of makes that assessment, who's a high risk woman. You test again at the 3rd trimester and then again at delivery. You just really want to, because it's a really easy way to treat it. You just treat it with IV penicillin and it's good. So you just really want to make sure that this woman doesn't have it to give it to the baby. All right, so that's syphilis. The next one's chlamydia. Chlamydia is really interesting. It's a intracellular bacteria, which I don't know how much you guys know about bacteria, but bacteria normally is not intracellular, it's extracellular. So that's really rare about chlamydia. So that's what I put this picture here. It's showing like chlamydia within a cell, which is really, again, really interesting. It's the most common bacterially transmitted STD in the US. I know that doesn't really have much to do with pregnant women, but it is an STD, STI, whatever. But 75% of women are asymptomatic. I can't tell you how many times I was even just shadowing and like someone had chlamydia and they had absolutely no idea that they had it. Like none. They had no symptoms whatsoever. And that's why, again, they really encourage all women to get tested at like their annual OBGYN appointment, especially if pregnant. So they have kind of down here like, okay, if you do have chlamydia, what can you get? And you can get endometriitis, cervicitis, pelvic inflammatory disease, which I believe I talk about on a future slide, and then just acute urethral syndrome, just meaning like basically it's basically a UTI. If you're pregnant, you can get all of this as well as issues now with the growing fetus. You can get chorioamnitis, so your chorion gets inflamed, your amnion gets inflamed, postpartum endometriosis, and then gestational bleeding. So that can happen. And then in neonates, when they're born, this is actually, they love to ask this. I should have like highlighted this. Is like if you have a baby is born and they have intrapartal transmission, like transmitted during delivery, they can get conjunctivitis. And they call that ophthalmia neonatorium, which why not just call it conjunctivitis? They can also get pneumonia from it, but usually it's like your baby's born and they're already going to have like pink eye, basically, and you're like, that's odd. So how you screen it, you just do a nucleic acid test, you screen it, and then you test all pregnant women very early on. And then if you're a pregnant woman less than 25 and high risk, you're screened again, which I think that the guidelines change all the time, so don't feel like you need to memorize anything. Here's Neisseria. Neisseria is a gram-negative diplococci, so it loves to live inside of cells. It's another intracellular bacteria. So these are cells, and then the gonorrhea is, I'm trying to highlight just one. Here's one gonorrhea. It's a diplococci, so it's like this. It like lives in twos and it stains pink. And you can usually find them inside of like white blood cells. All right, so this is the second most common cause, so this is behind chlamydia. 50% of patients are asymptomatic, so a little less than with chlamydia, but it's really, really good at causing pelvic inflammatory disease. So again, chlamydia and gonorrhea, these are what cause pelvic inflammatory disease. I can't remember if pelvic inflammatory disease was on your syllabus, but just very briefly, I wanted to talk about it. It's really so simple, right? So chlamydia, gonorrhea, they come in through the vagina. It's a sexually transmitted disease. And basically what happens is it can ascend. It can just keep going. So it's in the vagina. It goes to the cervix. So it passes through the cervix. Now it's in the uterus. And then it can keep going. It can go through it can go to the fallopian tubes. It just ascends. So that's why they call it like a pelvic inflammatory disease. And that's kind of where you're getting like just inflammation of all of these parts of the pelvis, basically. And this can actually lead to infertility. You can get scarring, because if you have inflammation here, that's not good. You're gonna get scars. You're gonna have not as good of a chance as like if you want to have a baby. The embryo is not gonna implant because there's scars everywhere. So that's why they really want to test for chlamydia and gonorrhea, because it's like if you test for it, you know it's there, you can get rid of it. You don't have to worry about PID. Okay. This is the most common predisposing factor to something called disseminated gonococcal infection. This is like, it's really weird. It's like you get gonorrhea, but then you get arthritis. It's really weird. It's just basically gonorrhea goes throughout the whole body. Screen it with a nucleic acid test, again, during the first delivery, and then it's the same transmission as all the other ones. Neonates can also get conjunctivitis. This is like so similar to chlamydia, but this one can also get conjunctivitis. You can get sepsis, arthritis, or you can get a meningitis from this, as the neonate. All right, next one is bacterial vaginosis. This is another STI, BV. The causative agent, this is the disease, bacterial vaginosis. Oh, did I miss? I missed your question. I'm so sorry. I'll come back to that. I'm so sorry. I was really on a roll with the micro. I'm so sorry. I'll come back to that. So this one, the causative agent. So bacterial vaginosis is the disease. The causative agent is Gardnerella vaginalis. So people get confused with it sometimes. They're the same thing. It's just one is the bacteria, one is the disease that the bacteria causes. But I see them interchangeably a lot of the time. Something that's interesting is Gardnerella vaginalis is a normal flora bacteria. It exists normally within the vagina, with the anal cavity, all that stuff. But what happens is it can overgrow. A lot of the times you have like these good bacteria, and then you have like other good bacteria that like they compete against each other. And sometimes if one of them drops off, like your pH balance changes for whatever reason, one of the types drops off because now the pH is too weird. Now we only have one and nothing's competing against it. So it just starts overgrowing. And that's kind of what happens here with Gardnerella vaginalis. It just overgrows. So it overgrows, and now that's when you get your bacterial vaginosis infection. This one's really easy to see in vignettes. I should have put a little buzzword here. I always see this in vignettes with BV, is sometimes the patient will be asymptomatic, or more commonly, they'll do what's known as, I hate this so much, but they call it the whiff test. And they basically get vaginal discharge and they smell it, they whiff it, and it smells like a fish-like odor. Really not a good mental image there. Yeah, don't love that. So that's a fish-like odor. I'm telling you, as soon as you see that in a vignette, they're not even trying to be tricky. They're getting at bacterial vaginosis. It's Gardnerella vaginalis, and it's normal flora that just got overgrown. Because sometimes they'll ask about, well, how did this patient get it? I guess this really isn't an STI. Sorry. I guess it can be because it can mess with whatever. But this can get spread to the developing fetus. It can be it can get spread intrapartumly. And another kind of key characteristic of this is you basically get the vaginal discharge and you look at it under a microscope slide. And when you do that, you look for what's known as clue cells. And clue cells are these vaginal epithelial cells. So they're really, really massively large cells. So really just massive cells. And again, just for this is a white blood cell. It's really tiny in comparison. This is a massive cell. This is an epithelial cell from the vagina. And you can see what's this purple stuff all over it. That's your Gardnerella vaginalis. It's just flooded over. It's just flooding your normal epithelial cells. So they call this a clue cell. And I have seen questions too where they straight up will ask, they'll straight up ask, what is a clue cell or whatever. And it's just your epithelial cell with Gardnerella vaginalis all over it. And it's for bacterial vaginosis. Again, it's not, since this is normal flora, it's not super bad that you have this. It's worse if you're pregnant and you have bacterial vaginosis. You can treat it, but again, it's really only if you're symptomatic to treat it. Okay, so those were kind of the ones that I could think of that were either STIs or relevant for moms to their baby. Because again, we're in repro block pregnancy. Yeah, so the torch test, this was specifically on your syllabus as well. So we're going to talk about what this is. It's not really a test. It's just it's a reminder to test for these 4 organisms. Okay, so you do need to know what each letter of torch stands for. So the first one is toxoplasmosis. And we'll talk about each one of those. O is null, nothing. It's just, O is just there. R is rubella. C is cytomegalovirus or CMV. And then H is for herpes simplex virus, and usually it's HSV2. So why do these get their own separate tests? Why are these so special? These can cause illness in women that may cause birth defects in their newborns. So we're a step ahead of can cause infections in the newborns. Now we're in full on these can cause birth defects. So it's kind of you need to test for these in your newborn. I mean, you end up testing for all, you saw, you get screened for syphilis, chlamydia, gonorrhea, you get screened for all of those as a pregnant mom, group B strep. But these are the ones that are if you don't test for these, someone's losing their job kind of thing. This is they can have a congenital defect. The baby can. All 4 of these can cross the placenta to the fetus, either during just regular development or during the actual process of birthing. And all of these are screened for during the pregnant woman's first visit. All right, so we're going to go through each one of these. So the first one is toxoplasmosis, and I put congenital before all of them because you can get all of these infections normally. You don't just have to be a pregnant woman to get these infections. It's just kind of to get congenital toxoplasmosis, it's you have to be pregnant and you're exposed in this way. Pregnant women don't respond similarly to infections as non-pregnant people. You saw that with the soft cheeses. Pregnant women can't have soft cheeses, but I can have a soft cheese if I want, So it's kind of that's what I'm going for. So toxo, I just want to put that out there. Toxo typically causes like brain lesions in normal people. Normal people that have like bad immune systems can get toxo and have different symptoms. Okay, so if you're reading about toxo and you're like, why does it not say anything about this triad? This is specifically when you get congenital toxo, which is a part of the torch test. I hope that makes sense. So it's just kind of like I'm talking specifically about mom getting it while pregnant and giving it to the fetus. What are the symptoms in the fetus or the baby once the baby is born? Okay. And I tried to put like one picture for each of these to be like, okay, what are they probably going to mention in a vignette? So with toxo, they're 100% going to talk about a cat. So how is the pregnant person exposed? Cat feces. They probably, if they're getting at toxo, they're probably going to mention a pregnant woman that owns a cat, pregnant woman that's changing a litter box. That's why they say if you're pregnant, never change and you have a cat, never change the litter box ever, because you can get toxo. And again, if I were to change a litter box and I'm not pregnant, I probably won't get toxo, honestly, because my immune system can fight it off. When you're pregnant, you're like kind of, sort of immunocompromised. That's why you can't have soft cheeses and change litter boxes. But again, just kind of pointing that out there. It's like this is specific for pregnant women and then their baby once it's born. So cat feces. So again, pregnant woman that has a cat, pregnant woman changing a litter box, they're talking about toxoplasmosis. You can also get it from raw undercooked meat. You can also get it from unpasteurized goat milk. But again, cat feces is going to be the more common one. So look for cat litter. And then classic triad, this is going to be in the baby once it's born if it were to get congenital toxo. Chorioretinitis, diffuse intracranial calcifications, and hydrocephalus. So chorioretinitis is basically like eye inflammation, like your chorion of your eye and then your retina of your eye gets inflamed. Diffuse intracranial calcifications just means like in your brain, within the cranium, you get calcifications. You get like they're like little white spots in the brain. This is actually what toxo is more of a neuro like bug, but again, it likes to go to the brain. But with pregnant women, think more of like eye and then also brain stuff. And then also hydrocephalus, which is just like too much cerebrospinal fluid in the head. So the baby can be born with a massive head, just very large head, because there's so much cerebrospinal fluid, the head starts enlarging. Because again, remember, not all like the plates of the head or whatever, the sutures are like completely like sutured shut. So it can shift and then you can get a really massive head. All right, so that's toxo. I just gave, again, one slide on all of these. The next one's congenital rubella. So for this one, I put a heart and blueberries, so we'll see why. So how is the pregnant person exposed? Rubella is really only if you don't have your MMR vaccine. That's pretty much it. So they're not going to say like unvaccinated pregnant woman. They're not going to say that. Usually what they'll say, and this is just what I've noticed, is that look for someone that's in a third world country. That's their buzzword for someone being unvaccinated. And like I said, like they'll talk about athletes, gymnasts, dancers for being like really strict on diet. This is like if you live in a third world country in a vignette, they're trying to get at that they're unvaccinated. I don't make the rules. It's how they're trying to get it across. And then the classic triad here is you're going to get a PDA. This is like congenital rubella is a PDA. This is a very commonly asked thing. So the baby will be born with patent ductus arteriosus. They won't say that. They'll just say the baby was born with a continuous murmur. So if you remember from cardio, continuous murmur, the only one is a PDA. Or like a machine gun murmur, that's another like way that they can talk about a PDA. So that's the first thing. You can get cataracts and you can get bilateral sensory neural hearing loss. You'll see a lot of these torch infections can cause hearing loss and eye issues. So I would really think the more important one is the fact that they have all three of these things. That's like more of the key that they have rubella or congenital rubella. Again, they're not going to say baby has sensory neural hearing loss. They're going to say baby failed the auditory exam because babies are given auditory exams when they're first born. So that's that. And then I put the blueberries here because a lot of the times, so this is not specific to rubella. I just want to point this out. Oh yeah, I wrote that. Not specific for congenital rubella. A lot of the infectious diseases can cause what's known as a blueberry muffin rash. But Again, what I've noticed is if they happen to include it in a vignette, it's usually when they're talking about rubella. I don't know why. It's just something I've noticed. So just again, look for PDA and look for your blueberry muffin rash. You can feel pretty confident that it's congenital rubella. And a blueberry muffin rash is when the baby's born. It's really sad. I didn't put a picture because I didn't like it. But imagine this is the baby's torso and like this is the head and the arms. Oh my God. But they're basically saying like this is like the muffin part, and then the baby's gonna have all of the. I mean, you can look it up. It's just I don't want to put it on here. I don't want to bum anyone out. And it's basically purpura. It's like these little bruises, but they're saying the bruises are like shaped like little blueberries, I guess. So it's like they have like these big blue circular bruises all over them, and it looks like an overall blueberry muffin. That's where it came from. Medicine man. Okay, next is congenital CMV, and I put a little healthcare worker here. And the reason I put a little healthcare worker is because of exposure. Really, the only way that you can get CMV is like not common anymore. And again, this is like not something that comes up that frequently, but so you can get CMV in contaminated blood, saliva, or secretions. So it can be like sexually transmitted in a way. It's not technically an STI, STD, but you can, because it can be in secretions. You can get it from saliva, so it can be like droplet secreted. But a lot of the times what you should look for in vignettes is if the patient had a blood transfusion recently. And the reason why is because, again, this is not a thing anymore because blood is tested if you donate blood, it's tested for CMV. Like it's on every single blood vial is CMV negative because they test it. But that's like the only way I can think of them putting this in a vignette is like, oh, the patient just had a blood transfusion and now this pregnant woman just had a blood transfusion and now she's having the baby's having these symptoms. Unfortunately, the symptoms are going to start getting really similar to a lot of the other torch infections. So again, it's like that one unique thing is going to be that blood transfusion thing. So some of the things you can see is hydrocephalus, microcephaly. So the baby can be born with the hydrocephalus again, the head's really big, or microcephaly, really small brain, can have calcifications just like with toxo. Sensory neural hearing loss. I guess this is the most common thing that you would see with congenital CMV, so I highlighted it. But again, almost all the other ones have hearing loss. You can have chorioretinitis, again, just like with toxo. And then you can also have hepatosplenomegaly and jaundice. So CMV can get into the GI tract. So you can see like enlarging, I guess. Like the spleen gets big, the liver gets big, and you can also get jaundice. Okay, but look for the blood stuff. All right, and then lastly, congenital HSV. So like I said earlier, usually this is HSV2. And why did I put this picture? I'd love to know. Oh, I know why. We'll talk about it. So with HSV, how are they exposed? So you'll go into way more depth about herpes in neuroblock. Herpes simplex virus they technically call it like a neurobug, which is really interesting, because it lives like basically in your, what's it called? Like your spinal cord, like part of your spinal cord. It just lives in it. So if you become immunocompromised, it can get reactivated. So it's kind of the same idea of like chickenpox and then shingles later in life. Shingles is a type, it's varicella zoster, so it's a little different from herpes simplex, but it's kind of the same idea is like you get chickenpox when you're younger, it stays with you until you become immunocompromised, and then boom, it can reactivate. And now it's shingles. It's kind of the same idea. Like I said, pregnant people are kind of sort of immunocompromised. They're not, I wouldn't call pregnant people immunocompromised, but they can't do certain things because their immune system can't handle it more than normal people. So they're like a twinge immunocompromised. So you can, if you've had herpes simplex virus in the past and like 99% of the population has, it can become immunocompromised. Sorry, it can reactivate because you could be technically immunocompromised. Or you're pregnant and then you come into exposure with contaminated skin lesions. So someone has skin lesions and then you come into contact with them. Now you can have primary exposure to HSV. Symptoms vary in the baby. So the baby can be born and having those same skin lesions. They call them like vesicular skin lesions. They look like vesicles that just want to like burst open. That's like what vesicular skin lesions are. It's very common in like all types of herpes to have vesicular skin lesions. You can have keratoconjunctivitis, which again, eye stuff. So the skin around the eyes can get red and inflamed. CNS symptoms, you can get meningoencephalitis. It's basically like a form of meningitis and encephalitis. So the meninges can inflame, the part around the meninges can inflame. And how that would present was, it just sounds like a sick baby. Fever, lethargy, irritability, poor feeding, seizures, the fontanelle in the back starts bulging, stuff like that. And then systemically, it can cause sepsis. So that's kind of where my little thing came from. Sepsis, I always think of like disseminated, just bacterial infection that gets everywhere. So we have a blood infection and then it can get to the lungs, for example. So I put that one for this one because, again, I feel like that's the most unique part of HSV. But again, they're gonna have to give you something that you can grab onto to be like, yeah, that's herpes simplex. All right, so that's your torch. Sometimes, I will say too, sometimes they include HIV in the H for torch, but in your normal torch infections, the H is HSV. But you can have congenital HIV, but I just didn't, I went with what like the normal baseline is. Okay, so this is not something you guys need to know. I just thought it would be interesting. Well, actually, I don't know if you need to know it. But are antibiotics safe to take during pregnancy? So again, a lot of the times you have a pregnant woman. What if you have a pregnant woman has syphilis? What if she has, I don't know, gonorrhea or whatever? Which antibiotics can you give them? And it's going to be depending on the antibiotic. And again, I really wouldn't memorize these. I would just kind of like start piecing. You're going to have to know these for boards 100%. So just kind of start looking at and like getting used to seeing these names. It's like, oh, you have a pregnant woman? Give them penicillin. They'll be fine. So generally safe is going to be penicillin, your cephalosporins, erythromycin, clindamycin. These are just 4 types of antibiotics. You absolutely under no circumstance can give the ones that I've bolded in black. And these guys, the teratogenic ones. So the contraindicated ones are going to be like your sulfa drugs. These are like UTI meds, nitrofurantoin, quinolones, metronidazole, chloramphenicol, aminoglycosides, tetracyclines. Can't really give them. Contraindicated, remember, means like you can't really give that. There's a contraindication. There's not an indication to give that. And then teratogenic. So I put my little sometimes you'll see I put like a little spider. It's my teratogen tarantula. So when I put this little symbol, it means that that's a teratogen. And teratogens, remember, are things that can cross the placenta and harm the fetus. So these are antibiotics that can cross the placenta. So I put tetracyclines, doxy, and streptomycin. Tetracyclines, I got this question on like both sets of boards, so I even bolded it. They usually will ask with teratogenic anything. It doesn't have to be antibiotics. Any drug that's a teratogen, they will usually ask like, what is the birth defect it causes? Which you don't have to know at this point. I'm just saying, I don't think so. And then again, like all drugs given to pregnant women and like anything for pregnant women, the highest risk is going to be during your first trimester. And then I just found I thought this was cool, like this little mnemonic, MCAT. So hopefully that doesn't trigger anyone with MCAT, right? But it's like, what does it cause? And then what's considered generally safe. Just something interesting. I don't think it's like super necessary to know these. And then finally, and then I'll go back to the question that I had missed from like a half hour ago. Male and female development, don't forget this. This is what I was talking about from last time. Just now that you kind of are starting to study repro and like learn more about repro, this is kind of what I was talking about. I think about it as if like this is like your unisex in the middle. This is undifferentiated. And then if you're exposed to DHT, what will it turn into? But if you're exposed to estrogen, what will it turn into? And usually this is external genitalia, but definitely know what the male and the female homologs are. So male, it's the glans penis, but in the female, it would be the glans clitoris. And then so forth and so on. All right. So the question, and repeating it for the recording, is, does estrogen regulate FSH and LH or just FSH? That's a good question. I think that this was for this slide. Sorry, I can't see on my little thing. No, not that one. Wow, how long ago was this? This one. This one, I believe. Or I don't even know anymore. Oh, maybe it was this one. Yes. Okay. Yeah. So estrogen, estrogen is specifically feeding back on FSH specifically. It can feed back on LH, But a lot of the times what you'll see is estrogen with LH is more so for that LH surge. It more so like positively feedbacks on LH versus it more so causes negative feedback of FSH. But a lot of the times too, like estrogen will feedback not only on the anterior pituitary and like block, FSH and LH both come from the anterior pituitary, so there will be a degree of feedback on LH from estrogen, but it also goes all the way back up to, actually, this slide all the way in the beginning when we were talking about PCOS. It also can feedback all the way up to the hypothalamus. So it can actually go up to the level of the hypothalamus, so it can actually kind of regulate GnRH release. So it can technically regulate FSH and LH. And again, this is not normal. Just a reminder to people listening, this is your PCOS pathophysiology slide. So just a reminder. But estrogens can technically affect LH, but it more so is for FSH for negative feedback. And then it's more of a positive regulator for LH. Yeah, good question. All right. There's tons of good questions for you guys to work on, but as promised, I really want to do an androgen insensitivity question. I just don't remember where it is. Hold on. Nope. This was actually, I actually have 2 questions in here that look like this. This was from when I made this PowerPoint like 3 years ago, whenever it was. I was studying for boards, and this was on one of my boards practice exams, and it was like everything that I had talked about in that tutoring session that day, and I'm like, wow. Okay. Here's the question. So I don't want you to, this is why I only want to do really this question together, and you guys know the answer, but I kind of want to just show how they word androgen insensitivity. And this is classically how they are going to talk about it, okay? So we're going to read it together. Sorry to take away one question, but I promise there's tons of questions in here. So this one is going to be, so again, 17-year-old girl. So 17-year-old girl comes to the physician because she has not yet attained menarche. So again, this is like one of those things where it's like, oh, this is a primary amenorrhea workup. So if you see like, oh, how would you diagnose PCOS? How would you diagnose Turner's? How would you diagnose androgen insensitivity? It's like usually a workup for primary amenorrhea, and that's how it's worded. 17-year-old, 16-year-old, not yet attained menarche, has not had a period yet. Remember, menarche is your first period. No personal or family history of serious illness. She is blah, 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 weighs this amount. This is usually only really helpful for when it comes to Turner's, because usually like Turner's patients are going to be like 4'5" or something. Like they're going to be small because they have that short stature. So examination shows normal breast development. Okay, cool. Scant axillary hair is present. So this would make me think, like that's testosterones, right? Because remember, your androgens are responsible for hair, especially axillary hair. I'd be like, okay, no testosterone. That's normal. She's a girl. That's normal. Abdominal examination shows a firm, non-tender left inguinal mass. I'd be like, what is that? Does she have an inguinal hernia? Like, what is that? And then pelvic exam shows a blind vaginal pouch. Okay, so it stops. So we have a vagina, but then it stops. And then ultrasonography does not show a uterus or ovaries. No internal female genitalia. Immediately you should be like, okay, this is not a female. This is not like an XX female. So then which of the following is the most likely cause of these patient symptoms? So you can kind of see like all of these, if you didn't know what the answer was, all of these sound good, right? Like you're like, okay, yeah, like she's a girl, but she doesn't have a uterus. Maybe the Mullerian duct didn't develop. Mullerian duct agenesis, right? So that's kind of what I kind of wanted you to like work through, like just get used to seeing how they word things. Like I would read this now and be like, this is androgen insensitivity. Like from the point that they said 17-year-old girl, I'd be like, oh yeah, no, it's probably not a girl. It's probably not a girl. So we have a girl coming in because there's primary amenorrhea, and then non-female internal genitalia. So internal, you want to like kind of like keep a chart in your mind. It's like, okay, internal genitalia is female. No, it's not. It's male. External genitalia is female because they talk about, normal breast development. So this is going to be female. So now you're already thinking, okay, do I think the body's responding to testosterone? And that's when you start looking for these other clues. So remember, testosterone, your androgens are responsible for your hair, right? Because remember with PCOS, when you have too much testosterone, that's going to be causing like the hirsutism. Here's the opposite. The body's making testosterone, but the testes are there, they're making testosterone, but the body's not responding to it. So we're gonna have scant axillary hair, barely any axillary hair. Again, that's testosterone driven. We don't even have we're starting to get a little suspicious that maybe it's a male because internal genitalia has to be male. And then it's like, okay, there's a blind vaginal pouch. It's like, oh, like that's estrogen acting on the outside, but then the inside, it's just not responding to testosterone. So it's again leading to that. And then if you're still not convinced and you're like, well, maybe it's still Mullerian duct agenesis, they also tell you there's a firm, non-tender left inguinal mass. Usually, again, in an instance like this, and that's kind of what I put on that slide, when they mention this, they're trying to mention that these are the testes that have not descended yet. Okay, so these firm, non-tender masses is the testes that haven't descended. So that's kind of like how you can figure out that it's androgen insensitivity. Like I said, I think these are like the hardest questions in Repro because I feel like all of these sound good, right? But this is androgen insensitivity, and it kind of goes through everything we've talked about. And I also wanted to mention just something I didn't mention, but Amboss does. And you can read this, go through it, but there also is going to be elevated LH and there's going to be elevated testosterone. So keep in mind that androgen insensitivity, it doesn't mean there's no testosterone. It just means that there's testosterone. It's just not, the body's not responding to it. So don't get thrown off when you have a 17-year-old female that comes in and they test her for testosterone and the levels are super high. And you're like, that makes no sense. She's scant axillary hair, other signs of not being a male. You're like, that's weird. Testosterone can be high. It's just the body's not responding to it. It's kind of like insulin resistance. Insulin's super high, body's not responding to it. And then the other thing is LH can also be super high because the pituitary gland is not responding to the feedback. Because remember, testosterone, if you go back to that one slide with the seminiferous tubules, testosterone goes back and it feeds back on LH. And then here, testosterone, again, it's being made, no feedback. The body's not responding to it. It doesn't see it. So you can have elevated LH because there's no feedback, quote unquote. Does that make sense? So this is kind of how Amboss went through figuring out that this is androgen insensitivity. Here, like I kind of mentioned earlier, how can you kind of tell the difference with androgen insensitivity and 5-alpha reductase deficiency? Remember, 5-alpha reductase deficiency, you really don't have breast development, and you also have that some degree of virilization when puberty hits. Remember, this overwhelming amount of testosterone is somehow able to make DHT. I don't even know if they know why, but I'm pretty sure it's like at puberty when testosterone spikes, it's like it's able to kind of like overcome, like it's able to like not completely overcorrect, but it's able to kind of like at least like cause some hair growth, as well as like they call it clitoromegaly because these are females, right? Like even in 5-alpha reductase, they look like a female. They're a male that looks like a female externally. So then you get this burst of testosterone. And now it's like the male's penis wants to start developing, but it's not DHT. It's not. So what happens is what now is externally the clitoris develops. And they call that clitoromegaly because now it's like it's developed. It should be the penis though, but it's not able to develop. So it just kind of swells. It gets bigger. So that's usually also another sign that it's like this should be a male. When clitoromegaly is mentioned, it's like that should be a male probably. It's just externally a female. And then the most common one that people picked was Mullerian duct agenesis, which would result in not having a uterus, right? And that blind vaginal pouch, because again, that's internal genitalia. But the ovaries would be present. And if you look back on that one slide with, how everything develops, the Wolffian duct and then the Mullerian duct, you'll see the ovaries are the ovaries are kind of like its own separate thing. Because the ovaries would be present there, axillary hair would be normal, and then because this is not a hormonal defect, this is an anatomical defect. I think those are the two really, but this is the thing, when it comes to androgen insensitivity, sometimes it's like they put like these things that sound really good, like Mullerian duct agenesis, that sounds really good, and it sounds like it could work, but there's always going to be one thing, and that's why it's like if you know that one chart really well and you do a lot of these questions and see how they're worded, I just personally think these are the hardest questions you're going to see on your exam personally. It's why I'm spending so much time with it. But anyway, I will put this up and you guys can go through it. And oh yeah, this was another one from another practice exam I did that also asked about something we talked about. But anyway, there's a bunch of questions on there. I'm going to exit out. Okay. Okay. All right, I'm going to stop recording.